Thank you very much for the introduction. So this is the only radiology session in the whole meeting, so I think it will be interesting for a change. And my topics today is about radiology in GI tract cancers. Here is the outline. I will talk briefly on role of imaging and choices and advantages and disadvantages of imaging. And then most of the time I will show a bunch of cases on the luminal GI cancers and then conclusion. Okay, let's start with the role of imaging and choices. Role of imaging in GI cancers are numerous, starting from screening for early lesions such as CT coronography for early CT colon or ultrasound for early hepatocellular carcinoma, or use it for detection and diagnosis of primary cancer, and then use it for staging, and then we can use imaging guided for biopsy and radiation therapy. After treatment, we can use imaging for assess response to treatment and then surveillance after treatment. In terms of imaging choices, what kind of imaging you want to choose, it depends on primary tumor type, questions being asked, patient's tolerance for the imaging study. For example, if the patients cannot stay still for a long time, MRI probably is not a good choice. And also depends on local expertise in your institution. And this is the slide showing the advantages and disadvantages of various imaging modalities. Ultrasound, particularly EUS, endoscopic ultrasound, it is quite good for early lesions because it could go into the bowel wall and visualize the bowel wall, and it has no radiation. You can use it for guiding biopsy. But the downside of EUS is that it has limited field of view, and bowel and bone can obscure the structure, so you cannot really see it well. CT is used very often in GI cancer, and the good things about CT is that you can perform it very fast, it has high spatial resolution, and it has a large field of view, which can scan from the whole body within a few minutes. The downside of CT is that it has radiation and it has limited physiologic and viability data. What about MR? MR is also the tool that we use very often. It is excellent in tissue contrast. We can access physiologic data. Information from T1, T2, and DWI will give you a lot of data in terms of physiologic information. It has no radiation, and it has high quality for solid organ visualization. The downside or the negative side is that it takes longer time, particularly when you compare to CT. And if you want to study the lung, it has limited evaluation for lungs evaluation. PET-CT, good thing about PET-CT is that you can assess metabolic activity. You can look at function assessment, but the downside is that it has low spatial resolution. So if lesions are small, they have a chance that you will miss the lesion, and also still have an effect of radiation. Last but not least, conventional fluoroscopy. It is the good thing is that you can see dynamic assessment. You can see peristalsis of the lumen, and you can see the lesion inside the lumen. But the negative thing is that you cannot visualize the extraluminal information, and there is still radiation. And this is another diagram showing that in terms of choice of imaging based on T&M stages. If you look at T stage, low T stage, you can see that endoscopic ultrasound has a very dominant role. It's very good to detect an early lesion. But for high T stage, the role would be CT. CT is the bread and butter for T staging. except for rectum, we will choose MRI because it has more ability to detect invasion, which I will show you in a case later. For end stage, for local nodal staging, EUS, CT, and MRI, it's very good. But for distant node metastasis, PET has a dominant role, as well as M stage. PET has a very sensitive for detection of metastases. So give you that background of choices and advantage and disadvantage of each modality. I would present to you daily case, practical day-to-day cases that when we approach patients and how imaging play the role in these cases. And I will focus only on the luminal GI tract from esophagus to rectum. Let's start with esophagus. This is a 67-year-old man presenting with dysphagia for about a month. And the first imaging of choice at that time is conventional barium swallowing, which is still a good choice because as you can see here that esophagogram shows nicely a large lesions here. This is the proximal to mid-esophagus show mucosal irregularity with, here is an ulcer. So it's a large ulcerative mass and narrowing the lumen. So based on this conventional imaging, the diagnosis is probably esophageal cancer. So based on that finding, endoscope was performed and proved to be a large constrictive mass that really narrowed the lumen that the scope cannot pass through it. Biopsy was performed and it's proved to be a squamous cell carcinoma. So next step is staging. And staging based on most guideline, chest CT, chest and abdomen CT is the recommended imaging for staging in CA esophagus. PET CT will use it for metastasis. EUS will use it if you want to, if you think this is an early lesion and you want to perform endoscopic resection. So the bread and butter of staging is CT. So we perform CT in this case, and you can see that there is a large circumferential mass of the esophagus. It involved all the way to adventitia, but it does not invade the structures nearby. So this is a T3 lesions. On sagittal view, you can see that there is the mass that extends from upper to mid esophagus. And there is already a node right here, carino node. So this is a 3T-N1-M0 based on CT staging 3A. So the role of imaging is for staging. Since the patient is non-surgical candidate, so the treatment at that time is CCRT, concurrent chemoradiation therapy. And at this point, CT is used as the simulator guided for radiation therapy. This is another role of imaging. After treatment for 3 months, we perform imaging again. And the follow-up is, again, using the barium swallowing, and you could see that the tumor disappeared. There is some aspiration of the barium to the left lung because of narrowing of the esophagus. Compare this to the previous study, you can see that the ulcer here is gone. So there's a quite good response to treatment. And we also use CT to follow up. And again, you can see that the lesions that used to be quite large here, now it's gone. What left here is diffuse thickened wall, which could be a consequence of post-radiation fibrosis. So we keep follow-up using imaging, CT, as a follow-up tool. And this is 5 months post-CCRT. It's relatively stable. You can see that this diffuse narrowing of the esophagus is still there because the tumor is disappear, but the effect of treatment is still there. So it's keep very narrow esophagus. And at that point, scope was performed again, showing that the lumen is very, very narrow, and the gastroenterologist cannot pass the scope in. Anyway, they biopsy, and it showed that it's only acute and chronic inflammation, no malignancy. So we still follow up. If you follow these patients long enough, or if the patient live long enough, we will surveillance them with imaging. And this is 9 months post CCRT. The narrowing persists and actually progress. At this time, it's caused stricture with dilatation of the proximal esophagus right here, as you can see on CT and then on barium swallowing. So this is the cause of the disease. At this point, scope was performed in order to do intervention, to do balloon dilatation to alleviate the symptoms of the patients. And also the imaging here is fluoroscopy using for helping guiding intervention. So the patient is treated with balloon dilatation with improvement of the symptoms. So in this particular case, the further plan of management is continuous surveillance. And continuous surveillance means that we will continue to use imaging studies until there is recurrence, metastasis, or other things. So this is the just an example of role of imaging in esophageal cancer. Let's move on to stomach. This is a female, 50 years old, presenting with anemia, weight loss, and abdominal pain. Again, I am not the one who choose the imaging. It's you guys who tell us what you want to do. And in this particular case, maybe conservative doctors or GP, I don't know, just say, oh, let's do upper GI study. And you might think it's not so good at this time, but in the old day, it has a lot of good information. And even at today, we still perform upper GI study, although not as much as before. But I will show you that the conventional barium study still has quite a nice role, because you can see nicely that this part of the stomach is poorly distended. This is gastric body. And you can see that the mucosa is irregularity, poor distension, irregularity of mucosa. Based on this finding, we can tell that this is probably a gastric cancer. Based on this finding, endoscopy was performed, showing the diffuse thickened folds of the stomach rugae, and there are ulcers here and some bleeding. And a biopsy showed that this is a adenocarcinoma with signet ring cell features. Again, the next step of cancer is staging, and the guideline also recommend CT as the first imaging modality for CA stomach. PET-CT, again, use it for research for metastases, and EUS is performed if you think this is an early lesion and has the potential to perform endoscopic resection. So in our case, I think it's a little bit advanced. We expect this is not an early lesion, so we perform CT. And here is the imaging. You can see here that the stomach here show diffuse thickened wall. And if you look at mucosa here, the one that enhanced, see that, the white one, the white part. Usually mucosa will be very, very thin, but here it's very thick because the mucosa was infiltrated by the tumor. So this is a linitis plastica pattern. And if you look carefully, you will see around here, this is around SMA, SMV, there is already soft tissue encasing the vessels, suggestive of invasion of the tumor into visceral peritoneum. So based on this information from CT, we can tell that this is a T4A lesion because already there is visceral peritoneal invasion. There is no node, there's no metastasis. So it's a T4A N0M0 lesion. So because of T4A lesion, it is considered to be surgical unresectable, and treatment is chemoradiation therapy. Again, CT is used as a guided therapy for radiation treatment. after treatment, of course, the follow-up is still a CT. This is post CCRT after 1 month. You can see that the stomach still show diffuse thickened wall, but the degree of mucosal enhancement is much decreased, and the encasement of the vessel is also decreased. So there is some response to treatment based on CT information. So we keep surveillance follow-up by CT. This is 1 year post-CCRT. It's still relatively stable. The stomach still show thickened wall, but mucosa enhancement is minimal. The encasement of the vessel is now resolved, so it's relatively stable. 2 years, also stable, and at this time, endoscopy was performed and confirmed that there is no evidence of cancer, so it reported as normal. But as you can predict that this stage T4A, it will be never cure. 1 year later, the patients develop ascites, peritoneal deposition, so-called Omento cake. There is metastasis to both ovary. So the patients develop carcinomatosis peritonei with Krukenberg tumor. So it turns out to be disseminated metastases. So at this point, metastasis, what we can do is palliative treatment. So we follow up until we see some changes with this imaging, and in this case, CT. So let's move on to small bowel. This is a female, 38 years old. She presents with abdominal pain. So at that time, we used CT to find out what is a cause of her abdominal pain. And we found that she had a 4-centimeter mass right there. At the right lower quadrant, it abuts the small bowel, and it's around the right side of adnexa, right adnexal region. So at this point, we think that she probably have a tumor because it's a solid mass. It's probably a small bowel cyst, or it could be an ovarian tumor. But before we want to investigate, the patients refused for any treatment, so we lost her. 2 years later, she come back with acute right lower quadrant pain, so we performed CT to look at what's going on, and you can see that right now there is fluid within the pelvis, and the fluid shows a little bit high density, suggestive of some blood in that is bleeding, and the mass it's real in here, submerged within the fluid, and it seems to change position compared to the previous one. This is the old study. This is moved to here. The mat there's some mobility, so suggestive that this mat is probably attached to the bowel, then the bowel swings or it keeps swinging, or it's at the adnexa, it twists. So we think that that tumor that we saw grows and then rupture, causes bleeding. Because of this information from CT, the treatment is surgery because some bleeding, some acute abdominal pain. And surgeon found that she has small bowel cyst, and small bowel resection was performed. And the surgeon found that the cyst already ruptured the capsule. It's not quite aggressive. It's only 2 mitotic per 50 high power fields, which if you look at this data, you can see that small bowel cyst 5 to 10 cm with mitosis less than 5, the aggression is moderate, metastasis rate is about 24%. But since in our patient, she's already had a rupture of the tumor, so this is considered to be a metastasis disease. So even though it has a low mitosis, she should receive systemic therapy. In this case, she will receive adjuvant imatinib. Okay, let's move on to colon. This is a gentleman, 81 years old, presenting with bowel habit change. And at that time, CT chronography was requested. I think it should have done, you should have scoped it, right? But whenever the patient is a little bit too old or not too frail, you offer to me, which I'm thankful because I could have a case to look at. So this is CT coronography was requested, and we found, and this is the 3D endoluminal view down here. You can see there is marked narrowing of the lumen with a regular mucosa with a mass like encroaching the lumen. And on 2D view, there is right here a circumferential mass involved rectosigmoid colon. There is node positive here. Here, node positive. So based on CT coronography that we use for screening or early detection, now we can detect, we can diagnose because it looks like cancer. And if you like the old imaging, we also can create the volume rendering that looks like barium to show you a apical appearance that we are familiar with. So this is probably a colon cancer T3 lesion, N1, M0. So based on one study, we could diagnose, we could detect, diagnose, and staging at one time. That is a powerful tool of imaging. Based on that, now scope was performed and confirmed a circumferential mass. Biopsy again suggests malignancy. So surgery was performed, low anterior resection, and pathological staging is PT3N1, similar to CT scan. And then surgeon requests CT six weeks after treatment to look at the anastomosis. And you can see here that it's a nice anastomosis without any leakage. So again, role of CT as assessment after treatment. What's next? In this case, further management should be adjuvant therapy because of a T3N1 lesions. Okay, this is my last case. We moved down to rectum. Female, 51 years old, presenting with rectal mass. We could palpate it, and biopsy confirmed that this is a moderate differentiated adenocarcinoma. At that point, the first imaging of choice is EUS because they probably think this could be an early lesion. But when they perform EUS, it turns out that the mass is quite large, about 4 or 5 centimeters, and it's already invaded the muscularis propria. So it is a T3 lesion. So EUS has a pitfall in that once it comes into T3 region, EUS cannot evaluate sphincters, which is very important information in colorectal cancer. It cannot evaluate mesorectal fascia. So the imaging of choice that is the best for high stage rectal cancer is MRI, because MRI could identify the sphincter nicely. And you can see here that this is coronal view. There is a large 4 or 5 centimeter annular mass involved lower rectum. On axial view, this is the internal anal sphincter right here. And you can see that this part, it's already invade internal anal sphincter and go into intersphincteric plane right here. So based on this imaging on MRI, this is a T3 lesion. So 3T-N0, but the location is so low that at this point, surgery cannot be performed, and we need to have a neoadjuvant treatment. So neoadjuvant concurrent chemoradiation was given, and 6 weeks after receiving CCRT, you can see how good it responds to treatment. This is MRI. Now the tumor is gone. You can see now, internal anal sphincter, external anal sphincter nicely compared to before treatment. So the mass is gone. So this is a very good tumor response. And based on MRI, this is complete radiologic response. No visible tumor mass. If you live in Europe or United States, this particular setting, they might prefer wash and wait therapy. Do nothing until keep follow up, keep surveillance by, whatever it is, and then when it's recurrent, you would attack that way. But in Thailand, it's not practical to perform close surveillance, close monitoring. So we usually end up with surgery after CCRT. such as in this case, we perform a low anterior resection and again confirm that there is no residual tumor left. It's PT0N0. The only tissues just review inflammation and dysplasia. And in this particular case, further management is surveillance. And again, surveillance, usually CT chest and abdomen. PET CT is not recommended. We would do it when we're suspicious of metastasis that is not so clear, so obvious or equivocal on CT. So in conclusions, I just show you example of cases that we see every day and how powerful imaging help us in daily basis. And again, I emphasize that we can use imaging for screening, for detection and diagnosis of cancer, for staging, and for guided biopsy and treatment. And after treatment, we can use it for assessing response to treatment and surveillance after treatment. I hope that's somehow useful for you. Thank you.
Hello. Thank you for your fascinating and insightful talk, Dr. Linda. Any questions from the audience?
Yes. Thank you, Dr. Linda. You mentioned the use of CT colonography. What's the smallest size polyp that CT colonoscopy can detect?
Yeah. Actually, we can detect small lesion like 3 millimeter, but it's not very specific. So the cutoff for us is 5 millimeter. So we will report CT coronography if we see 5 millimeter lesion. If it's less than that, there is a chance of false positive. So we will not, we might say it is 3 millimeter, but this is non-significant lesion. So we will call it when it's 5 millimeter. So for 5 millimeter, 5 to 7 millimeter, we have sensitivity about 60 to 70%, but if it's up to 1 centimeter, we go up to 90+%.
I think we could take like another question. Nong Peng. Organizer.
Hello. Yeah. Actually, we have a question that do you have any recommendation for imaging modality, like in case for follow-up after treatment in patient with high risk for contrast-induced nephropathy?
With what disease? With
for example, like your first case that you give an example that you use like barium swallowing for follow-up. So I'm not sure if adequate to use the barium follow-up.
Oh, barium.
Yeah.
I think in the first case, well, we just used barium swallowing to compare with the first study. Plus, there is post-treatment stricture that I think the clinicians want to see the size of the lumen of the esophagus, but the adequate one would be CT. You need CT to look at a response to treatment. If there is any residual tumor, if there is any lymph node, if there is any lung lesions, things like that. So only conventional fluoroscopy is not adequate for cancer.
Well, in case that patient has a high risk for contrast-induced nephropathy.
Contrast-induced what? Nephropathy?
Yeah.
Or contrast-induced nephropathy, you mean kidney?
Yeah, correct.
You don't have to worry that if you have good renal function. We will worry if the patient has abnormal renal function, particularly if GFR is below 50, then we will start to worry. But we have a way to face with it, because sometimes contrast media is very important to really completely assess post-treatment of the cancer. So if you cannot use contrast on CT, we would shift to something else, maybe like PET scan could be a role here, or MRI. There is a lot of alternative. But I just tell you that in general, CT is the bread and butter for assessment of cancer.
Okay, thank you.
Thank you, Dr. Linda.